Hola, buenas tardes a todos. Continuamos con la sesión de hoy del módulo de dolor y en este webinar contamos con la participación, la inestimable participación del profesor Andrew Davies, que es uno de los médicos de cuidados paliativos de mayor reconocimiento a nivel mundial y precisamente por el tema que que va a tratar en esta sesión, que es el dolor irruptivo. De hecho, es una de las personas que ha establecido tanto la definición como los criterios de dolor irruptivo, por lo cual es para todos nosotros, para la universidad, para el ICO y para las personas que trabajamos en cuidados paliativos en nuestra comunidad, un gran honor su participación en nuestro máster. Desde un punto de vista práctico, el profesor Davies hará esta presentación sobre el dolor irruptivo, en la cual también ha planteado la sesión con algunos casos clínicos, de tal manera que si alguien a sus preguntas quiere participar, que levante la mano, intentaremos darle paso, o bien que haga algún comentario a nivel del chat. Professor Davies, it's a great honor for us that you participate in this in our master degree in this lecture. As I mentioned in Spanish, Professor Davies is a professor of palliative medicine in the Trinity College of Dublin in Ireland, and also palliative care physician in Our Lady's Hospice in that country. Is one of the most well-known palliative care physician, mainly for precisely in this topic, breathing pain. Is one of the people that established the definition and criteria of breathing pain, but his career is not only about pain and opiates, but also in another symptoms as serostomy or constipation. And it's a real pleasure that you be here with us and also participate with you in another collaboration. Thank you very much, and is your time.
Thank you, Jesus. I shall try and share my screen. Hopefully you can see my slides. So first of all, I'd like to say thank you very much for the invitation. I feel very honored to have been invited. And so thank you, Jesus, Agnes, and Xavier. I tend to talk very quickly, but as I'm speaking to a Spanish audience, I'm going to try and speak more slowly than normal. And I'm unfortunately going to speak in English, despite my first slide being in Spanish. So I'm trying to move on my slides, but they don't seem to want to move on. So there's the English version of the title. Just a disclosure. So over the years, not recently, but in previous years, I have done a lot of work for various pharmaceutical companies that produce the so-called rapid onset opioids. So I've received funding for lecturing and taking part in advisory boards and also for research. But a bit like this lady, who I'm sure is very familiar to all of you, Melania, it was nothing to do with the fact that Donald was a multi-millionaire, that she fell in love and married him. And equally, what I'm going to tell you is nothing to do with the fact that in previous times, I've been paid money to talk about breakthrough pain and the rapid onset opioids. and I've traveled around the world talking about that. So what I'm going to tell you is what I really believe. Some of the things may be a little bit controversial. They certainly were when we first started talking about them. I think the whole idea that giving oral opioids to manage this thing called breakthrough pain, which I'll explain in a minute, was very controversial. But I will talk about the controversies as we go through. So I'm going to start off with something that's quite fundamental, and that's really to talk about what is breakthrough pain and what isn't. But before I get into the main part of the lecture, I want to present a case. And this is a real-life patient that was admitted to our hospice a few months ago. And it just illustrates, I think, a very important point. So this is a man with metastatic prostate cancer. You can see from the X-ray, he has widespread bony metastases, a mixture of sclerotic and lytic lesions. He's had prostate cancer for a while. He's on hormone therapy, or has been on hormone therapy, but has progressed through that. He's had palliative radiotherapy for pain in his pelvis and had been managed at home by the community palliative care team. But it was decided that to try and get on top of his pain, to get his pain better controlled, it would be appropriate for him to be admitted to the hospice for a short time, just so that he could be assessed, his medication could be changed more rapidly. And so you can see here that before he was admitted to the hospice, he was taking morphine, modified release morphine, 60 milligrams twice a day. And in addition to that, he was taking immediate release morphine, 20 milligrams, and he was taking that up to 4 times a day, or 4 times a day. He was also taking paracetamol. He was also taking a non-steroidal. In this case, he was taking naproxen. And he'd had, from his oncologists, some bisphosphonates. So he was admitted, and the junior doctor that admitted him looked at the medication he'd had, looked at how many extra doses of the immediate release, the oral morphine he'd received in the previous 24 hours, and in fact, over the previous few days, and increased the dose of his modified release morphine to 100 milligrams. So essentially, he added up all the extra doses of the liquid morphine and added it to the background medication. And as has been standard practice over the years, when he increased the regular dose of morphine, he also increased the PRN dose of the morphine as well. So it went from 20 to 30. And that sort of ties in with the sort of European recommendations about the dose of PRN opioids, of breakthrough medication, if you want to call it that, of it being about 1/6 of the daily dose. And we'll come back to that later on in the talk. So the next day, the patient had still had several extra doses of the liquid morphine, the immediate release morphine. And so his background dose of morphine was increased further. And that seemed to have an effect because, as you can see, during this day, he'd had only 2 extra doses of the liquid morphine. But he was now confused and agitated. He was having hallucinations, and he was having myoclonic jerks. So he'd become opioid toxic. And the reason that he'd become opioid toxic is because he'd been managed as somebody who had uncontrolled background pain. And so in the correct way of managing uncontrolled background pain, his background dose of opioid has been steadily increased. But actually, he didn't have uncontrolled background pain. He was having episodes of breakthrough pain. And by increasing his regular morphine, instead of improving managing his breakthrough pain, actually what happened was he became toxic. So what's really important to understand is when you use the term breakthrough pain, when you use the term breakthrough medication, you need to make sure that you're actually treating that condition. So lots of people with cancer pain have flares of their pain, but it's not always breakthrough pain. And this is really important because the management is different depending on the type of pain that the patient has. So some people will have no regular pain, no background pain, but just intermittent, short-lived episodes of pain. And that's been deemed transient pain. There are other people who have a constant pain. It's not well controlled, but at times it flares up, it gets worse. That's uncontrolled background pain. And then there's true breakthrough pain. And I'm going to talk a bit about the definition and the diagnosis of that in the next couple of slides. And I'm going to spend quite a bit of time talking about this because this is fundamental. If we don't make the diagnosis or get the diagnosis correct, then the management will be wrong. And like the patient I just presented, potentially the treatment we give will actually make the patient worse, not better. So flares of pain can be very different. Treatments can be very different. So I've already alluded to this. Okay, so I'm going to talk a lot about this paper. And as you can see from the slide, this is a very old paper. It was published in 2009. And despite the fact it's so old, a bit like me, a lot of the things written in this paper are still true. And this was a paper that was written by, if you like, an expert group from the Association of Palliative Medicine of Great Britain and Ireland. That's the professional organization for doctors working in palliative care in the UK and Ireland. And this is a well referenced article. It doesn't show up very well, but there's been over 400 citations of this paper over the years. And as I said, it was published in 2009. The actual paper, the actual sort of consensus was developed in 2008. But what we did a few years ago was actually review the more recent, if you like, guidelines that have been produced, national and international, and the evidence base to see whether actually things that we suggested in those original guidelines were still relevant. And as you can see from this, one of the authors was Joseph Portasalas, who used to work in Barcelona, but is now, I think, happily retired. And what this review showed was that actually, despite the sort of 10 years that had gone past between the original guidelines and this paper, that most of the things in the original paper were still true. And if anything, there was evidence further evidence to back up what we'd recommended. So we'll start off with the definition of breakthrough pain. So if you look in the literature, there's lots of different definitions, but there is one common feature, and that is that you can't have breakthrough pain unless you have background pain that is well controlled. And I'll come back to that point. Again, quite a lot of the guidelines that are out there use our definition, and I'll show you that in the next slide. And there was this Delphi study published again by Joseph Portasalis in 2015 of professionals in Spain, healthcare professionals in Spain, and they commented that there was a high degree of agreement with our definition. It was sort of the working definition that was used by Spanish palliative care professionals. So this is the definition. It's like a lot of definitions. It's quite long, but there are a couple of things that are really important. So, as I said, with most of the definitions, there's this important factor about you have to have controlled background pain. And what this definition also highlights is there are two sort of subtypes of breakthrough pain. So one is incident pain and the other is spontaneous pain. And I will come back to talk about the subtypes in a minute. And the reason why this was included in the definition was at the time, particularly in the American literature, there was a third type of breakthrough pain, and that was so-called end-of-dose failure. So that is the patient's pain got worse just before the next dose of analgesic was due to be given. And we felt that just reflected poorly controlled background pain. And actually the management of end-of-dose pain, end-of-dose failure, is actually to increase either the dose of the background medication or the frequency of the background medication. So following on from the definition, we developed some diagnostic criteria. And again, there are some other diagnostic criteria out there, but our criteria are the ones that seem to be most frequently used. And again, there's another Delphi study, again, of Spanish healthcare professionals. And again, this Delphi study came out with the conclusion or the result that our algorithm was felt to be very useful and tended to be used in clinical practice. And so the algorithm really consists of three questions. The first one is, does the patient have background pain? And by that, I mean, does the patient have pain that's there for most of the time, or would be there most of the time if they weren't taking analgesics? If they do have background pain, is that background pain adequately controlled? And we could spend the whole evening talking about, what constitutes well controlled, adequately controlled. Because we were dealing with a palliative care population, we chose a very simple verbal rating scale to assess the degree of control. So that was either none, mild, moderate, or severe. And what we felt is that if patients said that their background pain was severe or even moderate, that it wasn't controlled and that we needed to do something. We needed to amend their medication. But if they said that they had mild background pain or no background pain, then that would constitute controlled pain. And then if the background pain is well controlled, does the patient have transient, short-lived exacerbations of pain? So if the patient meets all of those criteria, then they have breakthrough pain. And it's a very simple, it's a very neat algorithm, or diagnostic criteria. You could question the different aspects of the algorithm, but if you follow it in clinical practice, then it's usually quite easy to determine whether the patient has background pain or uncontrolled breakthrough pain, and then that will guide you towards the best management. So what's really important, and again, I just want to reiterate, is that not every exacerbation of pain is breakthrough pain. If you have somebody who has uncontrolled background pain and you're titrating up their opioids, and their pain gets worse at a particular time, that is not breakthrough pain. And if you give them extra doses of morphine, oxycodone, whatever your favorite opioid is, that shouldn't be called breakthrough medication. And again, as I've already suggested, end of dose pain, end of dose failure is not breakthrough pain. So I'm going to talk a bit now about clinical features. So again, when I was talking about the definition, I said that the way it was worded was to highlight the fact that there were two different subtypes of breakthrough pain. The first is spontaneous pain. So this is pain that comes on out of the blue. There is no particular reason why the pain happens. And this is very difficult for patients to deal with because they never know when they're going to have pain. The other subtype is incident pain. There is a clear trigger to the pain. And incident pain can be divided into volitional. It's something that the patient does. So in the case that I presented, the patient got pain when they moved. If they sat down, lay in bed, they didn't have pain. But when they moved, they got pain. Then there's non-volitional pain. The patient has no control over whatever it is that brings on the pain. And an example of that would be somebody who maybe has rib secondaries, rib metastases, and has a cough. The patient can't help coughing, and when they do cough, they get the pain. And the third big group, breakthrough pain, is procedural pain. We do something to the patient, and that brings on the pain. So the thing about incident pain is, particularly the volitional and procedural pain, is it's predictable. And therefore, there are different options to managing that than perhaps spontaneous pain or non-volitional pain. So it's really important as part of the assessment to work out not only do they have breakthrough pain, but what type of breakthrough pain do they have. The other thing to say is that even within these groups, there's quite a bit of heterogeneity, variation. And the treatment is different depending on the individual patient, the individual pain. So these are two of my patients. They both have incident pain. They both have volitional incident pain. The picture on the left-hand side of your screen is somebody with a bone metastasis, or a woman with a bone metastasis in her femur from breast cancer. So pain-free at rest, she stands and walks on the leg, gets very severe pain in that leg. The person on the right has oral mucositis as a result of a bone marrow transplant. So again, their pain is well controlled at rest. If they try and eat or drink, they get severe pain. So they both have volitional incident pain, but the management is very different. The woman on the left needs to have the hip stabilized with an operation. She needs post-operative radiotherapy, change in her systemic treatment as well as analgesics. The person on the right, this is a self-limiting condition. This will settle down within a few days, a week or so. And so the patient just needs to be supported during that time to eat, to drink, needs analgesics as well. So management, very different. There isn't a one-size-fits-all management strategy. And that's why the sort of traditional teaching about breakthrough pain, you give somebody a sixth of the daily dose of oral morphine or whatever other opioid you use, doesn't make sense. And again, I will come back to that later in the talk. So I want to just highlight this study. And again, you can see that Joseph was involved in this study. And this was a large European study, 1,000 oncology patients under palliative care teams. And what we did is we used the diagnostic criteria to identify patients who had breakthrough pain. And then we looked at various characteristics of the pain. So I'm going to go through these slides. So first of all, in terms of the type of pain. So you can see that there was a mixture of pains amongst this group of patients. And not surprisingly, there is a small proportion, well, not that small, about 14% of patients who actually have a mixture of the different subtypes of breakthrough pain. That's not really surprising. We know that people with cancer pain often have multiple types of pain. So it's not really surprising that they might have multiple types of breakthrough pain. And what is really important is that how you manage in these patients their spontaneous pain, spontaneous breakthrough pain, may be very different from how you manage their spontaneous incident pain. So again, assessment is key to managing these patients. And in terms of, how often patients get the pain, or sorry, the number of episodes they get, there's a big range. So for some people, breakthrough pain is an inconvenience. It's not a major issue for them, but for other people, it is. It's a severe impediment to their quality of life. Now, again, this is really important. This is the time to peak intensity. And this really is one of the timing of breakthrough pain episodes is one of the things that guides us to how we, the sort of treatments that we might consider. So for a lot of patients, the pain reaches its peak intensity very quickly, within 5 to 10 minutes. And you can see that there is a difference between incident pain and spontaneous pain. But for some people, it comes on much more slowly. So for a lot of people, they need something that's going to work very quickly. For others, that's less of an issue. And again, that's relevant when you think about what treatments you should be considering in these patients. What about the duration of treatment? Again, very variable. But for most people, if you don't treat it, the breakthrough pain will improve within 45 to 60 minutes. Again, a big range. And what's important about this is that if you have somebody who has an episode of breakthrough pain that lasts for less than 10 minutes, there is no pharmacological intervention, with the possible exception of nitrous oxide, that is going to treat that episode of pain. So your management needs to be around trying to prevent the patient having episodes of breakthrough pain. So all of these characteristics will guide you to the best treatment for that individual patient. Okay, what about the, excuse me, the severity of the pain? So for most people, when they get breakthrough pain, they rate it as being either moderate or generally severe in intensity. What about the impact on activities of daily living? So we used the brief pain inventory in this study, and these are the interference subscales. So the change in color from green to blue represents the median value, and 0 means there's no interference, and 10 means there's worst possible interference. So as you can see, for most of these activities of daily living, breakthrough pain had a significant impact on the patient's activities of daily living. And there were differences between the different types of pain. Come back to this. So for instance, patients with spontaneous pain were more likely to have problems with their mood and were more likely to have problems with their sleep. The issue about the mood was that it was unpredictable. And so they were living in fear of the pain constantly. The people with incident pain, it was more things like being able to work, being able to walk, people with incident pain had more problems with those sort of activities, which is not surprising because for a lot of people, movement is the thing that triggers instant pain, particularly patients with bony disease, bony metastases. Okay, so I've said this a couple of times, assessment is really important. If you don't assess the patient properly, then you potentially will give them the wrong treatment. But equally, you need to reassess the patient, and you need to have clear goals of treatment, which need to be agreed with the patient. I'm just going to briefly mention the breakthrough pain assessment tool, the BAT. This was developed by myself and my PhD student called Catherine Weber. It's a really nice little tool for assessing the breakthrough pain and monitoring the response to treatment. So it's 3 sides of A4. The first side is just the algorithm. And then the second side is really about relevant characteristics. And the third side is around the assessment of response to treatment in particular. And what's really important is that the sort of traditional ways of assessing pain using numerical rating scales, looking at changes in the numerical rating scales, or even looking at the frequency of breakthrough pain is not necessarily appropriate in patients with breakthrough pain, because those may not change even if you are actually achieving something with your treatment. So what's really important is to look at the impact of the pain on the patient. So to give you an example, if you have somebody with bone metastases who gets pain and movement, with a lot of our patients, by making different changes, maybe referring them back to the oncologist for consideration of radiotherapy, by amending their background medication, we can increase their mobility. We can increase the amount of time, the distance that they can walk, the activities they can do before they have to stop with the pain. But if you just look at something crude like the number of breakthrough pain episodes a day, they probably will be exactly the same. But what brings on the pain, what the patient can do before they get the pain, is very different. The severity of those pains may be exactly the same, but instead of walking 10 meters and getting pain, they can now walk 200 meters and get pain. They can get on with their life. So it's really important that you assess, particularly reassess, what is important, what is relevant to the patient. And it again depends on the type of pain the patient has, what is important to the patient, and what is feasible. So these are some of the things that we look at, that we consider when we talk to the patient about their treatment and when we're reassessing them. Okay, management. So these are the recommendations from the APM guidelines. And I'm just going to go through them fairly quickly. So the first few relate to assessment. So we should be looking for breakthrough pain in our patients, and we should then be assessing their breakthrough pain. There's no point finding out they have breakthrough pain and then just giving them, for argument's sake, a sixth of the daily dose of oral morphine. We need to understand what the underlying cause of the breakthrough pain is, and we need to come up with an individualized plan for each of the different breakthrough pains if they have more than one pain. And that sort of leads on to recommendation 3 about management being individualized. We need to think about what the underlying cause is, and for most of the patients we see with cancer-related pain, it's related to the cancer, and so we need to think about can they have further anti-cancer treatment to improve their pain. But with patients living longer on treatment and more cancer survivors that we may or may not see in our clinics, actually it's not the cancer that's causing the problem. It's some sort of effect of the cancer treatment, or it could be a comorbidity. We need to think about, are there any precipitants, or in the case of incident pain, what are the precipitants, and is there something we can do about that? So in the example I gave about somebody with rib metastases and a cough, why are they coughing? Can we do something to suppress the cough and therefore help the pain in that way? We need to think about, can we modify their background medication? Will that help? Sometimes increasing the background opioid, although it's not recommended, can make a big difference, but that's to a very small group of patients. But if the patient's got breakthrough pain, which is neuropathic in nature, could adding an adjuvant actually be the best treatment for that breakthrough pain? Similarly, patients who have breakthrough pain related to abdominal colic or muscle spasm, could specific medications targeted at those types of pain be the best option? But for most patients, even if we can do some of the things that I mentioned on the previous slide, most of the patients require so-called rescue medication, breakthrough medication to manage the episodes of pain. And in most cases, opioids are the treatment of choice. The reason for that is, if you look at non-opioids, paracetamol, non-steroidals, they have a relatively long onset of action. And so they're not useful for treating these short-term episodes. Yeah. So I'm going to come back to this, but just again talk a bit about the dosage, the traditional teaching about giving fixed doses. 6 of the daily dose in Europe, 10th of the daily dose in the US. That is not appropriate, and I'll show you some data to highlight that in a minute. Non-pharmacological interventions can be really useful, and patients use these while they're waiting for the drugs to work. And there's a variety of things that can help: heat, cold, massage, change position, relaxation techniques, distraction techniques. All of those things are used by patients, by multiple patients, and all potentially can be very helpful. And then obviously there are interventional techniques that in a select group of patients may be very helpful. And the last recommendation is, again, just to reiterate about reassessment, the importance of reassessment. Okay, so recommendation 7 is that opioids are the rescue medication of choice for breakthrough pain. That's fairly uncontroversial. However, the next thing that we suggested in the guidance caused lots of controversy because we stated that oral opioids are not the more rescue medication for most breakthrough pain episodes. And I remember presenting these recommendations at our national palliative care meeting and being criticized by the then president of our association for suggesting that, that what was standard practice was not appropriate. But I want to explain to you why we said that. Like all things, we need to give individualized treatment to our patients. And the right opioid depends on a whole range of different things. Depends on the pain, depends on the patient. And what is really important is actually the temporal characteristics, the timing of the pain. That's probably the biggest factor in choosing the preparation or the optimal preparation. But the one thing that's really important to stress is that opioids don't work for all types of breakthrough pain, just like they don't work for all types of background pain. And if you have a patient that's been given an appropriate dose of a drug that should work in an appropriate time period, so for instance, a patient's in the hospital and they get a parenteral dose of an opioid, a subcutaneous injection or intravenous injection of an opioid, and it doesn't help their pain, then it's highly unlikely that an oral opioid or a rapid onset opioid, transmucosal opioid, will make any difference to the pain either. And we need to reassess patients and acknowledge the fact that for a lot of patients, opioids don't work and oral opioids don't work. And this is the reason why oral opioids don't work. So I said earlier on that a typical episode of breakthrough pain lasts 45 to 60 minutes. The onset of action of oral morphine, oral oxycodone, oral hydromorphone is about 30 minutes, sometimes a little bit quicker, but that's the onset of action. The peak effect occurs at 60 minutes. So just as the breakthrough pain episode is getting better, the drug is starting to work. But the drug continues to be in the system. So for a lot of patients, for at least 50% of the time they have in their breakthrough pain episode, the painkiller, the opioid, is doing absolutely nothing. For the last 50% of the episode, there is some effect, but then the pain gets better on its own, but the opioid is still in the system and potentially causing side effects. And actually, if you talk to patients, particularly patients who are relatively well, particularly patients who are still working or leading very active lives. They have worked this out, and they won't take a dose of their oral opioids, particularly during the daytime, because they know they get limited effect, but they do get problems with things like drowsiness in particular. And it's not unusual when you challenge professionals about the use of oral opioids to manage breakthrough pain. People say, but this patient says and is convinced that their pain got better after about 10 minutes or whatever. Unless the patient is unique in terms of their physiology, there is no way that an oral opioid can work within 10 minutes or 20 minutes. 20 to 30 minutes, maybe. So if the patient's saying that they have pain relief in a shorter period of time, then there's only 3 possible reasons for that. One is that they're being a good patient. They're telling you what they think you need to know or want to know. So the pain is still there, but they're just telling you what you want to hear. The other is that it's a placebo effect, or more likely, it's spontaneous resolution of the pain. So again, it's really important that when patients are given extra doses of opioid for breakthrough pain, that we assess the response. Does it work? How quickly does it work? Does it cause any side effects? And based on those answers, then need to make an educated decision about whether we continue with the oral opioids, whether we try something different, or whether try something different as in a different drug, a different formulation, or whether we try something completely different in terms of trying to treat the underlying cause, or use non-pharmacological interventions, or use interventional techniques. Too often, we just persevere with treatments that don't work. Okay, so there are other options. A few years ago, pre-COVID, there were many more options than there are now. And most of those options were based on fentanyl drugs, or fentanyl-like drugs. And to try and get over this delayed onset of action, the drugs were given via different routes, transmucosal routes. So intranasal, oral transmucosal, so buccal, sublingual. There were even some preparations of inhaled opioids. They never really got to market, certainly not in Europe. And there was even a so-called pain pen, which is a bit like an insulin pen, so patients could self-administer subcutaneous doses of opioids. So lots of different options for managing the pain. This is a network meta-analysis that was done a few years ago by John Zepatella and others. And what this forest plot shows is how quickly and how effectively the different preparations work to manage pain. So the 2 at the top, the 2 most effective drugs are the intranasal fentanyls. The one right at the top is the just the fentanyl. It's just fentanyl on its own. The one underneath it, the fentanyl is combined with pectin, and that was to try and improve the absorption, the amount of drug that was available for absorption. The pectin helped the fentanyl sort of stick to the nasal mucosa. actually what it did is actually slowed down the absorption of the drug. So the intranasal fentanyls work much quicker than all of the other options. The option at the bottom, the MSIR, that's morphine. They work quicker and they are more effective. The drugs in the middle are the oral transmucosal fentanyl products. And of all of those, the sublingual fentanyl Abstral is, again, the quickest and the most effective of those preparations. So the intranasals will start to work within about 10 minutes. Again, there's a bit of variability. The oral transmucosals, depending on the formulation, but if you take the Abstral or sublingual one, you probably get reasonable analgesia within about 15 minutes, certainly within 30 minutes. And the important thing about these drugs is that they have a short duration of action. So they get in quickly, they're very effective, and they don't hang around longer. So they better fit the profile of a breakthrough pain episode. But again, as I alluded to earlier in the clinical features, not everybody's breakthrough pain comes on quickly. Not everybody's breakthrough pain lasts for 60 minutes. And so for some people, actually having an oral opioid, a drug that takes 20, 30 minutes to start to work and reaches a peak after 60 minutes, might be the best profile for managing that patient. Okay. So the business, the philosophy about giving a sixth of the daily dose. So this is written in most European guidelines, the European Association of Palliative Care guidelines, and it is it is based on no evidence at all. It's just simplicity. So a dose of oral morphine lasts for 4 hours, 4 to 6 hours. There are 24 hours in a day. 4 into 24 is 6. So that's where the 6 of a daily dose came from. Now, when we produced our recommendations, we said that the dose of opioid should be determined by titration. And I will show you the reason why we suggested that in a minute, the study that was based on. There was very little evidence when we wrote these guidelines about dosage in of oral opioids in particular, managing breakthrough pain. But all of the new fentanyl products, all of the new transmucosal products, in their studies, they started on a low dose and titrated up. And when the results were published, when the results were available, they looked at the relationship between the dose of these products needed to treat breakthrough pain successfully and the background opioid that the patient was taking. And they found there was absolutely no correlation at all. So there were some people who were on really big doses of, for argument's sake, morphine, needed very small doses of fentanyl to treat their breakthrough pain, and vice versa. And I will show you some data in a minute. This is a figure from our guidelines. The thing about titration as well, and this comes back to the individualized dosing, is that for some patients, the most important thing is to get rid of their pain, all of their pain. For others, it's a trade-off between improving the pain and not getting side effects. And so you need to agree with the patient about what you're trying to achieve with the breakthrough dose. And titration is a two-way step. You can titrate up, but you can also titrate down. And if you're using an oral opioid, then you could start at a sixth of the daily dose. But you need to titrate up. The number of people where a sixth of the daily dose will be the right dose is relatively small. Some people are going to be underdosed with a sixth of the daily dose. Some people are going to be overdosed. So again, just like the background medication, we titrate that, we should be titrating the breakthrough medication. Okay, so lots of the studies that I've shown you have been quite old. I wanted to show you this study, which is relatively new. Well, it's still, well, nearly 5 years old. So this is a study from David Currow in Australia. And what they wanted to do is they wanted to look at different dosages of oral opioid to treat breakthrough pain and see whether there was, any correlation between, whether there was any dose effect. And essentially what they did is for each patient, they worked out a sixth, an eighth, and a 12th of their daily dose of opioid. And in a random fashion, they gave patients those dosages of breakthrough medication. This is oral opioids. And what you can see is actually it didn't matter whether patients had a sixth, an eighth, or a 12th of the daily dose. The improvement in pain was the same. So their conclusion was that as there's no difference between time to pain relief, reduction in pain intensity, overall pain control, that you might as well give a 12th of the daily dose. It's a smaller dose. It's less likely to cause problems. So essentially what this study shows is that what we've been doing and what we've been recommending in Europe for a long time is actually maybe twice what patients actually need. But one of the things that wasn't highlighted very much in this paper, but is really relevant, is in this study, the median time to pain relief in these patients was 120 minutes. Just again showing that oral opioids aren't a very good treatment for lots of patients with breakthrough pain. And in fact, there was an editorial, I mean, this paper was published in the European Journal of Pain. There was an editorial, one of the, as you can see, by Paul Kepsat and others. And they highlighted that this was a really important study. They highlighted that they reiterated the importance of titrating opioids and reiterated the fact that oral administration of opiates was not optimal for many patients with breakthrough pain. And actually, when they delved into the data a bit more, they found that only a third of patients had acceptable pain relief at 30 minutes. So 2/3 of the patients who got oral opioids weren't getting adequate pain relief within 30 minutes. And again, they highlight this point about that many patients who perceive having an improvement, actually it's probably the pain just gets better on its own. But this is actually not new at all. We knew nearly 25 years ago that there was a poor correlation between the dose of morphine that you need to treat breakthrough pain and your background opioid from this study. So this was the first ever study looking at the actic lozenge. And it's a very neat study because what they did is in each it was a crossover trial. So in each arm, they titrated the breakthrough medication when the patient was on morphine and when they were on the Actic lozenge to the optimal dose. And then they compared it to the dose of opioid that the patient was taking to manage their background pain. And this is what they found. So if you look at the figure on the left, so this shows the successful dose of oral morphine and the background medication. So you can see from the different points, which are in individual patients, there are patients who are on relatively low doses of morphine, who needed relatively big doses of immediate release morphine to control their breakthrough pain, and vice versa. So, for instance, if you take this patient down here, you can see my mouse. That patient is maybe taking less than 60 milligrams of morphine. Sorry, this patient up here is taking less than 60 milligrams of morphine over 24 hours to control their background pain, and yet needs 60 milligrams to treat their breakthrough pain. Now, that's clearly a very extreme example, but they found no correlation between the dose of morphine needed to control breakthrough pain versus the dose of morphine needed to control their background pain. And in the same study, they found exactly the same thing in patients who were using fentanyl as their breakthrough pain. They also found no correlation between the dose of Actic needed to manage breakthrough pain and the background medication. So although it makes life more complicated for us, we should be titrating the dose of breakthrough medication as well as titrating the dose of the background medication. And I've already said that. So a couple of other things to just highlight. So there's lots of talk about if you have more than a certain number of, in some guidelines, there's talk of that you can only have a maximum number of breakthrough pain episodes in a 24-hour period before it becomes uncontrolled pain. I don't necessarily agree with that. This particular magic number of 4, I think, is based on the fact that in all of the trials of the newer rapid onset opioids, patients were restricted to a maximum of 4 doses a day. And so 4 has become a magic number. In terms of that, these products have a very short duration of action, about 1 hour. And despite the fact that the summary of product characteristics say that they shouldn't be used more than 4 times a day, clinical practice supports that they can be used more than 4 times a day. I would say if you're needing to use it more than 4 times a day, you always need to review if there's something else that you should be doing. But it doesn't make sense that a drug that lasts only 1 hour, you can only use 4 times a day, whereas an oral opioid, which lasts 4 to 6 hours, you can use up to every hour, according to the European guidelines. So the 4 a day in the summary of product characteristics relates to the fact that they could only be used at a maximum of 4 times a day during the clinical trials. And so the pharmaceutical companies can only promote drugs to be used in the same way as they were in the clinical trials. Should say that none of the oral opioids are licensed for the mentioned breakthrough pain, but we use them to treat breakthrough pain. And this is going back to the point about the number of episodes a day. So if you follow the APM guidelines, then what's most important is not the number of episodes, but the total duration of the pain. And so if you just get fixated on the number of episodes, then it doesn't really help. As I said, so people who have multiple episodes, people who require multiple doses of breakthrough medication, probably need a different strategy to manage their pain. And I just wanted to just reiterate about this. There are other treatments for breakthrough pain, and something that we sometimes find very useful, although we mainly use it for procedural pain, is nitrous oxide. You can't use it long term because you develop tolerance and because of neurological problems related to vitamin B12 deficiency. But you always need to think, is there something else that could be used, even if it's only short term? So a couple of issues with the rapid onset opioids. One of the big issues is around the cost. So they do appear on the face of it to be more expensive than an oral opioid. But there's no point using a cheap oral opioid if it's actually not working, and particularly if it's causing side effects. So you need to not just think about the cost of the drug, you need to think about the cost of the alternative or the cost of not treating the patient. And if a rapid onset opioid means that the patient becomes more independent, and that means that their carers can go out to work, or they don't need social care being provided, then it is cost effective. For a lot of patients who are prescribed oral opioids, those drugs have minimal, if any, effect. Okay, then there's the concerns about abuse and addiction. And there are clearly some patients who have had problems with these drugs, but it's a bit like the issues with the drugs we use to treat background pain. There are some people that are prone to misusing drugs, abusing drugs, have a history of addiction. The drugs don't themselves make somebody into an addict. A lot of people who run into problems, it's down to poor prescribing and poor monitoring of the patients. If you're a drug addict, what you want to do is prevent withdrawal from your opioid. And so the thing that drug addicts are trying to do, or would prefer to have, is a long-lasting opioid. That means they need less doses. So a drug that lasts for 60 minutes isn't very useful in preventing withdrawal. Yes, the rapid onset may give you a quick buzz, but actually, when you're an addict, that's not really the driving force. The prevention of withdrawal is the driving force for continued use. The other thing to say is that if we're really worried about abuse and addiction, then there are other things that we need to be much more worried about. Now, this is old data again, but this is from the EU pharmacovigilance database of reported adverse events across the whole of Europe. So this is from 2018. So population in Europe is 200 and whatever million people. So you can see that the number of cases that have been reported is relatively small for these rapid onset opioids, and much less than, for instance, oxycodone and pregabalin. I can see that there is somebody's got their hand up. I don't know what to do now. Right. There's a question I think from somebody about what to do if you don't have rapid onset opioids. I can come back to that at the end, if that's okay. I'm not sure what the other question is. Okay, we'll come back to that in a minute. So I think that the bigger concern for us is around the long-acting opioids. And if you look to the US and the problems they're having, then a lot of those issues are around particularly things like OxyContin. But the big issue for me at the moment is pregabalin and gabapentinoids. There is not very much evidence that they are effective for management of cancer pain, cancer-related neuropathic pain. They cause a significant amount of side effects, including cognitive effects. They are associated with respiratory depression. They also remove the tolerance to respiratory depression that patients develop when they've been on opiates for a little while. And there is increasing evidence that the rise in death rate from opioids is significantly related to co-administration of gabapentin, pregabalin. So these are the things that we need to be worried about. Okay, so it says conclusion. I have a few more slides and some cases that we can discuss. So the first thing is that, you know, we need to move away from the way that we've managed lots of conditions in palliative care. We've come up with guidelines, and they've been very much, you do this for everybody. We need to realize that everybody is different. Everybody's pain is different. Everybody's breakthrough pain is different. And the optimal treatment needs to be individualized. In terms of managing flares of pain, exacerbations of pain, it depends on what the underlying problem is as to what you should do. And titrating the background opioid can be very useful if you've got uncontrolled background pain. If you've got breakthrough pain, it can be a disaster. And like the case I presented, can lead to opioid toxicity. So you need to really assess the patients properly and reassess the patients properly. Having said, you need to be careful about increasing the background pain. For some patients, and particularly patients with a reasonable performance status who have instant pain related to bony metastases, but who are well motivated and want to walk, then sometimes increasing the background pain can help, can allow them to be more mobile. But that's a select group of people. So again, historically, we've been told you shouldn't do that. But as I said, for some people, that can be a very useful strategy. Okay, So I don't know whether anybody wants to ask any questions or whether I've got some cases to present, whether that would be helpful. Just want to see if there's anything in the comments.
Andrew,
Yeah,
there is a question in the chat.
yeah.
Rosa Martinez asked you, we mentioned before that there is some students from Latin American countries, and there are some problems to access for some medications.
Sure.
And Rosa asked you if in a country where we don't have transmucosal fentanyl, what would you recommend for the management of breathing pain? What can we do in these countries?
Well, I think the first thing to do is if you don't have transmucosal opioids, okay, is not just give an oral opioid because you don't have anything different. I think you need to think about, can you reduce the number of episodes of breakthrough pain by changing the background medication? You need to think about whether you can use non-pharmacological interventions to manage the breakthrough pain episodes. But I think even in Ireland, and when I was in the UK, even when it was where I was working, it was difficult to get hold of the transmucosal opioids. There's always something you can do, but unfortunately, lots of people were just being given extra opioids. Even when their pain wasn't opioid sensitive, even when they were reporting that it wasn't working. So I think there are things you can do, but you just need to go back and reassess the patient. Think about, as I said, do they have neuropathic pain? Do they have some sort of other type of pain where adding in a non-opioid to their background medication could reduce the breakthrough pain? Can a non-pharmacological intervention help? It's difficult. I mean, these rapid onset opioids are a very useful group of drugs, but even in my practice, the number of people where we use them and it changes their life, it's the solution to their problem, is relatively small. So for most of the patients, with breakthrough pain, we can improve their breakthrough pain without needing to use these drugs.
Thank you very much. There is another question. Are there any recommendations for transmucosal fentanyl in vascular pain? For instance, dialysis patients with vascular pain?
I don't know whether there's any specific guidance. I mean, I think, as with all opioids, I think there's a resistance, or there's an increasing concern about the use of opioids for non-malignant pain. But even with malignant pain, I think, particularly long-term use of opioids, there are concerns. I mean, I think, I mean, I have not in the scenario that you presented here, but I've had people with very bad peripheral vascular disease at the end of life, who have got very painful legs. They are dying and requiring opioids. That occasionally we have used these in those patients, but it's a very tiny group of patients. It's not something that I would do routinely. I think Yeah, so I don't have an experience, and I wouldn't recommend it. I wouldn't say you couldn't use it, but I wouldn't. The one thing I would say is that again in the summary of product characteristics, it says you shouldn't use these drugs unless somebody is on an equivalent of 60 milligrams of morphine a day or 25 micrograms of fentanyl. That again comes from the clinical trials, but we do use these drugs in patients on lower doses of opioids in some circumstances, okay? But it's like everything, you have to choose the patient. You have to be sure that the patient's going to follow your instructions, and we closely monitor those patients. But yeah, there is we use these drugs in a it's a relatively small percentage of patients, a very select group of patients, and we always give them a trial. And if we're not sure that it's making a big difference and it's not causing side effects, we stop them.
Claudia Cabeza has another question. We can use subcutaneous morphine or intravenous morphine instead of oral morphine or another oral opiates.
Yeah, I mean, I think that's the thing, that you know, if you're in an inpatient unit, or even if the patient's at home, intravenous maybe not, but subcutaneous, so that will work very quickly. You know, that will work within 5 minutes. In some places in the United Kingdom, not so much in Ireland where I am at the moment, but end-of-life care patients, there are programs where they teach the family to give injections. And so yes, if it's feasible, if it's appropriate, a intravenous or a subcutaneous injection of morphine or oxycodone, whatever, will work very quickly. I mean, people have looked at using other opioids in different ways. So, for instance, in pediatrics, they use intranasal diamorphine for fractures in some cases. So that you can think about other routes for some of the opioids, but the problem is the absorption, and again, how long it takes. I mean, if you try and use other opioids to absorb them through the buccal or the buccal mucosa, it's very slow absorption, so you might as well just swallow it. But yeah, you can also use parenteral.
Oh, thank you very much. I don't know if there is another question for the audience.
I've got some. While you're waiting to look for a question, so this is some data that's also from the European study to look about the acceptability of different routes. So you can see here, this is the Spanish data. So Spanish patients would be very happy about using oral transmucosal route, not surprisingly. But less so about using the intranasal route. And this was what we found in other countries as well. And the reason for that is because traditionally we don't give drugs through the nose. Or the drugs that we do use through the nose are for things like upper respiratory tract infections or allergies. And so, but patients, will use different routes if they can be persuaded that the drug will work. And I think what's really interesting, going back to your point, Jesus, about injections, is that patients would have injections. They're happy to have subcutaneous injections. Their breakthrough pain is so distressing that they don't mind being injected to get rid of the pain. And that's why they developed this pain pen. It never came to market. But as I said, it was like an insulin pen where patients could inject themselves. They actually used hydromorphone in the pens, but there was a very nice study from the Netherlands showing that it was a very effective treatment. Patients liked it, not surprisingly. It was very safe, but unfortunately, it never became commercially available. So, so patients will try different routes if they're available. I've got one case. So one of the things that I can go back to some of the other cases in a minute, but one of the problems we used to get with when we still potentially get with the oral transmucosal preparations is that a lot of our patients have a dry mouth. And so the problem with a dry mouth is that affects how the drugs work. So if you don't have any saliva, it's difficult for the drugs, the formulations to dissolve. Also, if you have a dry mouth, your pH is very low in the mouth, and that affects the pharmacology of the drug, the characteristics of the drug, which decrease the absorption. But equally, you can get damage to the mucosa due to cracking of the mucosa due to infections. So the absorption of the drugs can be really really different from what you'd expect. And we actually reported on a case of a patient who had this. I don't quite know why we were using Actique, because we never really used Actique, but this is the fentanyl lozenge, and you have to rub it against the inside of your cheek, and it dissolves there. And we had a patient who had a really dry mouth and was using the Actique and was getting some effect from the Actique, but after only after about 15 to 30 minutes. But you'd expect the lozenge to have been completely dissolved in that time. But despite him rubbing it back and forth, only half the lozenge dissolved in that 30 minutes. And so what we did is we treated his dry mouth with a drug called methanosyl chloride, which is a muscarinic agonist. It's a bit like pilocarpine. And as a result of having more saliva, the lozenge would dissolve much more quickly. The fentanyl would get absorbed much more quickly. And so his onset of relief went from 15 to 30 minutes down to 15 minutes. And because more of the lozenge dissolved, we actually managed to reduce the dose of his Actique. So again, this comes down to the importance of titration. This comes down to the importance of the individual patient. You know, these drugs can be very helpful, but they're not panacea. And for some patients, you know, they can't use the drug. So the Actique, you have to have, you know, you can't be fatigued. You have to be able to use your arm. So that's why we don't use it very often or at all now, why we use some of the other preparations. And for some patients who've got really bad oral problems, for instance, head and neck patients or patients having radiotherapy or bone marrow transplants, when we do need to use these preparations, we'd use an intranasal, because then you don't need to worry about the about saliva. Okay, so there's a few more cases. I mean, they just really sort of demonstrate different aspects of this. So they're all variations on the sort of original case that I presented. So, and what would you do with this person? So this patient, this is the history. Okay. So what is important here is that the patient's in pain all of the time. They're scoring 5 out of 10 all of the time. Okay, so they do not have controlled background pain. Yes, they get more severe pain on walking, but actually the treatment here is not to give them some sort of breakthrough medication. It's to manage their background pain. And in this patient, actually, when we increased their background medication, or a number of patients we've had like this, actually their breakthrough pain goes away, or it gets significantly better. So again, the clinical picture is quite similar to the first patient that I presented, but the management is different. In this case, it is appropriate to increase their background morphine. In the first case, it wasn't. Yeah. So this is this is somebody whose pain is well controlled at rest, but has severe pain on standing, not even movement. So with this patient, okay, there are different things that you could do, and we've explored all the options, the anti-cancer treatments. We've explored adding in other things to their background medication. This is a patient who wants to mobilize. Now, the problem is if every time he stands he gets pain, you can't give him breakthrough medication every time he stands. He wants to be up all the time. So again, with this patient, even though his background pain was well controlled, we just increased his morphine a little bit. And what that did is it meant that he could stand without being in pain, and he could walk a relatively short distance before he got pain. So we increased his morphine a bit and then added in this case, it was a rapid onset opioid. So, the first two cases I've just shown you, we did the same thing, even though they were very different clinical presentations. This patient, he's got spontaneous pain. Okay, there is no point in increasing his background opioid. There is no point in giving him anything else. He just needs something that works quickly for when it happens. And so he again is a good patient to try a rapid onset opioid, because the pain is very severe and it comes on unexpectedly and it comes on quickly. Whereas this person, it's incident pain, and he knows if he walks 50 meters, he will get severe pain. In this case, you can use an oral opioid, because what you can do is give it to him 30 minutes, 60 minutes before he goes for a walk. So he's got adequate analgesia in his system for when he starts to walk. And that worked really well for this guy. Just simple oral morphine. And it meant that he could walk or do things when he wanted. He had control over that. And because the morphine was in his system when he started to walk, he could walk much further because he had adequate analgesia on board. So just with these 4 cases, the management was the same for the first 2 cases, even though they were very different. The management for the second 2 cases, they both had true breakthrough pain, but what they needed, what the optimal treatment was very different. So they're just there to just reiterate that there isn't one treatment that works for everybody. Some people, oral opioids are what they need. Some people, rapid onset opioids are what they need. For some people, they don't need opioids at all. So that even if you don't have the rapid onset opioids, and I would say that, you know, maybe, I don't know, 15% maximum of the people I see, we would consider putting on a rapid onset opioid. And I see, you know, one end of a spectrum of very difficult patients. But the vast majority of patients, you can do other things. They don't need those drugs. So even if you're in a country where they're not available, or near where they're not available, there are plenty of other things you can do. It's not easy, okay, but I think that why we've been so bad at managing pain before is because we've tried the same thing in everybody. There are lots of options. You just need to find the right option for your patient.
Thank you very much, Professor Davies. It has been a really interesting talk and really complete. And Agnes Calcina?
Yes, thank you. I wanted to share an opinion because I really love when you mention that everybody is different, and also that, of course, the optimal treatment needs to be individualized, because some of us who are here, we work in cancer institutes, and you know that oncologists, they need to follow some guidelines. And 2 or 3 years ago, they asked us to reassess our pain guidelines from the institution, and they wanted us to prescribe morphine for everybody. So it was very difficult to try to convince the pharmacologists who do the guidelines to try to individualize for each patient. So it's very interesting. We use a sentence from Eduardo Bruera and from some of you saying that we need to individualize each patient to assess, but for us it was hard to explain that to a group which is mainly following oncology guidelines. And so
Agnes, sorry to interrupt, Agnes, but they treat the patients individually. They look at the tumor, they look at the biology of the tumor, and they give completely individualized treatment. That's what oncology is, isn't it? So we're no different.
For us, it's very helpful to know also your opinion about that.
Except we're more clever than they are.
And also, I wanted to share or to know your opinion about the current use of those fentanyls now in Ireland, because some years ago in Spain, as we mentioned before starting the webinar, and I have a colleague here, Marga Álvaro, we were talking about several times, that in Spain 5 or 7 years ago, there was a huge use of all these fentanyls. And as you mentioned, maybe only 15% of our patients would need it. So I don't know if in Ireland has happened more or less the same, that maybe now we try to assess more correctly, and then those fentanyls are prescribed also when strictly needed. Or I don't know why some years ago there was more use of those medications. I don't know about your opinion.
So there are a lot of the companies have sold the products. And so there are a limited number of companies now that have rapid onset opioids. The companies that do have them aren't marketing them at all. And in some cases, it's quite, I mean, it seems to be quite difficult to actually get hold of the drugs. So I think the use in the UK and Ireland is much less than it used to be. And it didn't used to be very high compared to, say, Spain. So I think the problem is that there are patients who would benefit from these drugs that are not getting them. And particularly, you know, if you weren't in practice pre-COVID, okay, for junior doctors coming through, that these are things that they're not seeing being used. They're not hearing about them, and so the amount that's being used has decreased a lot. I think even when there were lots of companies promoting the drugs, they still in the UK and Ireland weren't being used as much as they should have been. Which is disappointing. I think the thing that I find really what I never understand is why some drugs get adopted in palliative care and others don't. It's the same with the Pomoras. They're very, they're not being used as much as they should be in the UK and Ireland. They are really good drugs. I mean, not for everybody, but but people are still using conventional laxatives, and so I think I think we if the companies don't make any money, then sooner or later they'll stop producing the drugs, and then we will lose something that could be very useful to some of our patients.
Thank you.
Thank you very much. I don't know if someone has another question or some comments. Nobody? Well, it's a little bit late. Thank you very much, Professor Davies. It has been a great pleasure to listen to you and your participation here, and it's a great honor for all of us. Also, it has been a very successful lecture, because there 95 people listen to you in the peak. It's really, really interesting talk.
Okay.
I don't know if Xavier, do you want to say something? To say goodbye? You are mute.
Thank you, because it has been a long and very helpful lecture, and also with a lot of new information. So this is helpful for us and for our teaching and colleagues. So thank you very much.
Okay, and I will. I mean, you have the presentation, but I will send you some references, and I will send you some papers that you can distribute if people want.
Okay, thank you very much.
Okay.
Jesus, any other words to close?
No, only say again, thank you very much, and we will be in touch for another collaborations.
Super.
And I hope everybody have enjoyed with this lecture, and we will see you tomorrow with other topics about pain. Thank you very much to everybody.
Good night, everybody. Take
Good
care.
night.
Bye.
Thank you very much.